Sir, we are streaming on YouTube. We will be live exactly by 7th. Sir, we are live, sir.
Just wait for a few minutes only. Within 5 minutes, na?
अजय जी,
Hi, ma'am. Good evening.
गुड इवनिंग जी। तो मैं अभी शेयर कर दूं अपनी स्लाइड या अभी पहले ज्वाइन
हाँ,
कर ले?
मैम आप शेयर कर सकते हैं अभी. Odin has also
ओके,
joined, ma'am.
ठीक है। इसमें शेयर और सिस्टम ऑडियो भी करना है?
Yes, ma'am. Technical team, are you here? Please help.
Yes, sir. Yes, sir. You are.
Diseases
Am I audible to you, sir?
have spread.
आपकी वॉइस एको कर रही है।
Technical team, are you here? Your voice is not audible properly.
Hello, am I audible, sir, clearly?
Yes, now audible.
Yeah. Please tell me, sir.
Yeah, please guide to ma'am.
Yeah. Ma'am, your camera is not visible, ma'am. Yeah, now
Yes.
yeah, the screen sharing is showing. It will just take 1 minute, I guess. Yeah, just minimize this and open the PPT, ma'am. In the bottom, can you see the PPT option in your taskbar? Yeah, perfect. Just open that, ma'am.
Yes, yes. Visible, ma'am. Ma'am, you are on mute.
Yeah, ma'am. Click on unmute, ma'am, please.
मैम अनम्यूट करना पड़ेगा मैम आपको.
You need
आप
to
म्यूट पे हैं.
unmute. Are you connected with a earphone or something like that, ma'am? Please.
आप मैम अनम्यूट हैं. आप म्यूट पे हैं. आप अनम्यूट करना पड़ेगा पहले आपको.
मैम का I guess mic का there is some issue. हाँ, click on unmute. Click on unmute.
अनम्यूट मैम.
Ma'am, click on unmute. Yeah,
Yes मैम. Yes मैम.
you
Yeah, I
are.
was not able to unmute at
हाँ,
that time.
yes now audible मैम.
Okay. Why it's showing multiple screens?
Yeah,
Is
that
it
that is screen mirroring, ma'am. Just open the PPT. It is fine.
okay?
Open the PPT मैम.
On the
हाँ,
slideshow?
yes it is showing मैम. Slide is showing.
Okay. Is it okay now?
Yeah,
Yeah,
perfect.
is it okay ma'am? Sorry, okay ma'am, okay. Ma'am, now I'm opening.
Okay.
Yes. Very good evening, doctor. Very good evening, all of you. I am Ajay Sharma on behalf of Glymac Pharmaceutical. Welcome you all to today's webinar on the topic of triple drug therapy. It gives me immense pleasure to introduce our speaker for today, Dr. Kamakshi Narula. Dr. Kamakshi is currently working at IGMC Hospital, Shimla, as a consultant nephrologist, bringing a wealth of experience and expertise to our discussion. Now, without taking any more time, I request Dr. Kamakshi to initiate today's webinar. Over to you, Doctor.
Good evening, everyone. It's my pleasure to be on this platform today evening. And without much ado, I would like to start the webinar, which brings us with a very important message of use of diuretics, especially the thiazide diuretics when we manage very difficult hypertension. So to start with, we are so today's topic is thiazide diuretics, which are foundational approach for cardiovascular protection beyond BP control. I hope my screen is visible to all and I'm audible.
Yes, ma'am.
Okay. So hypertension is defined as a persistent increase of the blood pressure on the walls of the blood vessels, and this blood pressure is an important risk factor which plays an important role in development of various cardiovascular, renal diseases and other metabolic diseases. But different guidelines vary in their criteria all over the world with different numbers which grade hypertension. So different guidelines says that as you can see in this table, the American Heart Association guideline of 2017 stages high grade 1 hypertension as a systolic blood pressure ranging from 130 to 139 and diastolic blood pressure ranging from 80 to 89 millimeter of mercury. It stages grade 2 hypertension as any blood pressure which is more than 140 and 90, 140 of systolic and 90 millimeter of mercury of diastolic blood pressure. The European guidelines of 2023 stages stage 1 hypertension as a systolic blood pressure from 140 to 159 and a diastolic of 90 to 99. Grade stage 2 hypertension being 160 to 179 and diastolic ranging from 100 to 109. Stage 3 hypertension as an SBP of more than 180 and a diastolic blood pressure of more than 110 or more than that. But as you can see, all major guidelines, they define different numbers for different grades of hypertension. One thing is common in them, that is every hypertension guideline do takes into account the cardiovascular risk assessment. So one message that comes out loud and clear is that cardiovascular protection should be ensured from the very first day of antihypertensive therapy. So we'll be discussing various guidelines and recommendations, especially for diuretics, especially hydrochlorothiazides, which has its place in various European Society of Hypertension, Indian Society of Hypertension, International Society of Hypertension. So American Heart Association recommends that for initiation of antihypertensive therapy, the first line agents should include a thiazide diuretic, a calcium channel blocker, and ACE or ARB should be included. So AHA says that thiazide diuretics, they are the first line therapy for treatment of hypertension. The European Society of Hypertension very nicely says that if we want to start any antihypertensive therapy for a patient, we can start with the monotherapy only in few patients, like who are low risk of hypertension, or the blood pressures are above, like high normal blood pressures, or they're less than 150/95, or a very frail elderly patients where we know that hypotension could cause more harm than with the drug may cause more harm. So otherwise, the first line therapy to start in most of the patients is a dual combination therapy. So the dual combination include, let me just use a pointer. So dual combination therapy may have various permutations and combinations. So first is the RAS inhibitor that is to be used, which can be used either along with a calcium channel blocker or a diuretic. So the next will be if the BP is controlled. Let's say if the patient tolerates this combination well, we have to either give a full dose or a dose where patient takes it, tolerates that dose well. For example, some patients are like on telmisartan may tolerate 80 mg of dose daily, but some patient may only tolerate 40 mg of dose. So 40 mg may not be the maximum dose, but it is a well tolerated dose. So along with the RAS inhibitors, we then add a calcium channel blocker or a diuretic could be added. If the blood pressures are not well controlled on this, then the next is triple drug therapy. So triple drug therapy says a RAS inhibitor, a calcium channel blocker, and a diuretic must be added. And the good thing is that beta blocker can be used at any step, whether it is as a monotherapy or as a dual combination or as a triple combination. Since apart from all these combinations, if still the patient has a poorly controlled blood pressure or not well controlled blood pressure, then it's a resistant hypertension, and then we have to treat resistant hypertension accordingly. The International Society of Hypertension guidelines says that the step one is you add a dual low dose combination. That may be A stands for ACE inhibitors or ARBs, C stands for calcium channel blocker. So a combination, a low dose combination of RAS inhibition and calcium channel blocker. The second step would be we would like to increase the dose to the maximum tolerated doses of both these drugs. The third step will be, if required, if the blood pressure is not still controlled, you can go for a triple drug combination, and a diuretic should be added at this point. So, and step 4, even if the drug is BP is not controlled on these drugs, then a spironolactone from ranging from 12.5 to 50 milligram can be added as a in cases of resistant hypertension. So even with the, according to the International Society of Hypertension guidelines, diuretics play a very important role in critical stages of hypertension like resistant hypertension. Indian Society of Hypertension divides the patients first into younger and older individuals. So with the younger individuals, we prefer RAS inhibitions first, that is either an ACE inhibitor or an ARB. And in the older patients, we prefer calcium channel blocker or a diuretic. Then the second step says that if it is not controlled on these drugs, then a combination of these drugs should be taken. Third step says that instead of calcium channel blocker or a diuretic must be there in a triple drug combination therapy. In cases of resistant hypertension, mineralocorticoid receptor antagonists like spironolactone or eplerenone should be added. And still, if it is uncontrolled, as we see in the patients of CKD, then other drugs like alpha blocker, beta blocker, centrally acting sympatholytics, or vasodilators could be used. So, all of the above guidelines indicate that diuretics can play a critical role in all stages of hypertension. So, which thiazide diuretic should be used, and why do we prefer hydrochlorothiazide? Hydrochlorothiazide, it achieves many targets of the hypertensive treatment to achieve the goals of antihypertensive management, which improves the cardiovascular outcomes and taking in care the patient's safety. So, accomplishment of all the antihypertensive treatment with hydrochlorothiazides. So, BP reduction with hydrochlorothiazide and combination, it says that there was a probe study that was done, and it was taken care, like effectiveness of hydrochlorothiazide along with telmisartan or a hydrochlorothiazide along with olmesartan was done. So here it was said that the conclusion was that is adding a 12.5 or hydrochlorothiazide to telmisartan 80 mg, it caused a greater reduction in the blood pressure as compared to when hydrochlorothiazide was added to olmesartan 20 mg alone, or when used as a monotherapy. So blood pressure reduction occurred with telmisartan hydrochlorothiazide. It was a more tolerated therapy as compared to other drugs, and in various stages of hypertension as well, and those which with in the patients in those who had major cardiovascular risks. So points to consider while we are treating patients with telmisartan and hydrochlorothiazide. Combination therapy is important to reach the blood pressure targets, especially in patients which have high cardiovascular risk. Telmisartan hydrochlorothiazide is a proven well-tolerated combination. It is effective for managing hypertension in various subgroups of people, patients who have high risk of cardiovascular events, and it also effectively reduces the blood pressure in various population of the patients, like advancing age, obesity, even in CKD patients, diabetic patients, and it's well tolerated. So it also says that for different levels of hypertension severity, it works well, and single pill combinations are present which are effective and have their minimal side effects, and the blood pressure goals are met more successfully. So how does hydrochlorothiazide provide a cardiovascular care? So there was one Lancet had published one study in 2019, which was Legend Hypertension, and it compared various drug classes effectiveness among many patients. So it was found that approximately 48 lakh patients were enrolled, and they were treated for more than 1 month, and they were followed up for more than 2 years, and they were found that in 48% of the patients, major drug class was ACE inhibitors, that too mostly lisinopril, and 17% of patients had thiazide or thiazide like diuretic, especially hydrochlorothiazide. Most of them were on hydrochlorothiazide, and 16% of patients were on calcium channel blockers like amlodipine. 15% of the patients were on ARBs, angiotensin receptor blocker. Most of them were on losartan, half of them, and few of them were on non-dihydroprotein calcium channel blocker, diltiazem. So this study had shown that thiazide or thiazide-like diuretics, they demonstrated a superior primary effectiveness over ACE inhibitors, reducing the risk by 16% for acute MI, 17% for heart failure and hospitalizations, and 17% for stroke during the initial management period. And it also, the safety outcomes said, as you can see this forest plot, that hydrochlorothiazide, it favored the all cause mortality and it favored the cardiovascular related mortality. So the Legend Hypertension study, it says that it compares the effectiveness of all the drug classes of antihypertensive, but there were no major differences between the classes. So it concluded that patient on thiazide or thiazide like diuretic had a significant lower risk of certain effective outcomes. Thiazide and thiazide like diuretic safety profile was better than the ACE inhibitors. Across patients which were initiated on monotherapy, approximately 50% were prescribed ACE inhibitors, and in 2.4 million ACE inhibitors new users had instead a thiazide or a thiazide like diuretic, more than 3,100 major CV events could have been potentially avoided. There was a subgroup analysis comparing hydrochlorothiazide and chlorthalidone in these subgroup of patients, and it was found that they both were comparable in terms of effectiveness. However, as compared to hydrochlorothiazide, chlorthalidone had a higher risk, slightly higher risk of hypokalemia and hyponatremia. As you can see in this forest plot, acute renal failure, hyperkalemia, hypokalemia definitely favors the hydrochlorothiazide. So chlorthalidone was not associated with any significant CV benefits when compared to hydrochlorothiazide. Its use was associated with greater risk of renal and electrolyte imbalances. And also the chlorthalidone and hydrochlorothiazide initiations with the various GFR decline was also studied. So across the all eGFR category, chlorthalidone compared with hydrochlorothiazide was associated with a higher risk of GFR decline, CV events, and hypokalemia. However, no significant difference between chlorthalidone and hydrochlorothiazide for dialysis or kidney transplant patients had occurred, with all-cause mortality, no significant hypokalemia and hyponatremia. So chlorthalidone was associated with high risk of GFR decline, CV events, and hypokalemia as compared to hydrochlorothiazide. The excess risk was attenuated in patients with reduced kidney functions, and these results suggest that no evidence to prefer chlorthalidone over hydrochlorothiazide. So one was diuretic comparison project between the hydrochlorothiazide and chlorthalidone, and which improved the CV outcomes. And it basically concluded that there was no difference in the CV outcomes among the elderly patients with hypertension. Among patients with prior MI, the benefit was observed. However, hypokalemia was more common. So when we say patient safety with hydrochlorothiazide, so it says that head-to-head comparison was done and published in NEGM, where it concluded that patients who received chlorthalidone did not have a lower occurrence of MACE than patients who received hydrochlorothiazide, but had a significant higher risk of hypokalemia. So, while we choose a diuretic therapy, it is very important to see patient safety first. Though blood pressure reduction is the prime target, a lower risk of hypokalemia is also equally important. Lower risk of hypokalemia with hydrochlorothiazide has been there as compared to chlorthalidone, and patients, however, with hypokalemia will not get any cardiovascular benefits with antihypertensive therapy as compared to patients who have a normal potassium levels. So the goal of our antihypertensive treatment should be a reduction in the BP should lead to reduction in the target organ damage, that is left ventricular hypertrophy, arterial thickening, plaques, proteinuria, microalbuminuria, arterial stiffness, arteriolar remodeling, reduced GFR, endothelial dysfunction, coronary calcium deposition. It also reduces the risk of coronary heart disease in MI, reduces congestive heart failure, ESRD, atrial fibrillation prevention, and accelerated hypertension prevention. So the take-home message becomes hydrochlorothiazide plays a crucial role in targeting all stages of hypertension with ensuring patient safety. In direct comparison, chlorthalidone did not show any lower rates of major CV as compared to the hydrochlorothiazide, but had a high risk of hypokalemia. Adding 12.5 milligram of hydrochlorothiazide to telmisartan 80 mg resulted in a more potent blood pressure control as compared to adding it to olmesartan 20. So telmisartan hydrochlorothiazide combination is efficient, well received in hypertensive patient with reduced cardiovascular risk. Thiazides, which reduces the cardiovascular risk. Thiazide or thiazide-like diuretics, it surpasses the angiotensin converting enzyme inhibitors effectiveness with reduced risk of acute MI, heart failure, hospitalizations, and stroke. Hydrochlorothiazide and chlorthalidone, it showcased similar effectiveness. Chlorthalidone exhibited a risk of GFR decline and hypokalemia. Current evidence did not favor chlorthalidone over hydrochlorothiazide, emphasizing comparable cardiovascular outcomes and highlighting certain risks associated with chlorthalidone, especially hypokalemia. Thank you.
So, thank you, ma'am. I would like to take a moment to thank you all your participation in today's scientific session. Your presence and engagement have made this event truly remarkable, ma'am. I would like to acknowledge and thank you all our attendees, your participation and interaction and dynamics. So, thank you once again for making this session a success. We look forward to your contribute, support, and participation in our future events. Thank you so much once again, ma'am.
Thank you.
Thank you so much.
Thank you.
Can I conclude with your permission, sir?